right. And arthrokinematically, which facet can't do what?
The right side is open and can't close.
Because it's stuck
Open.
There you go. All right, and that's why it's rotating to the left. Now, if you remember, when we're treating FRSs, especially once we get into the thoracic spine, it's recommended to be give the capsule and the capsular structures a little bit of protection. So instead of just taking them from the flexed position that they're in dysfunction, we often will implement first a bit of gapping and rotation to help make sure that if we were to come down into extension, that we don't impinge the capsule or those little meniscoid tissue that are at the ends and borders of the facet joints. So if we just wanted to do it aggressively, I mean, we could certainly come into ERS right, but extension side bend rotation right, sorry. But it's much better if we're in this position to actually do a little bit of translation and rotation first, gap that right side so that now the facet joints aren't coming down so sharply in extension initially, gap the facet joint, and then after a couple repetitions in neutral, eventually translate them back and then finish off the rotation and side bending into extension. All right. And that's exactly what's set up for you in the pictures in 305. So if I can have somebody come up, we'll actually do the correction and we'll talk through it step by step. All right. Frank?
Quick question. A couple of us were talking during break, and we were wondering, like symptom-wise, a patient coming in with an FRS, what are they like pain? Because they're not going to come in like I have this motion loss. They're going to come in, I'm hurting. So what pain would they have? Like, would they have pain with the movement they're restricted in, or?
They're going to have pain with the. They're going to have pain local to the area of the facet dysfunction.
Okay, so it's no like specific pain, and then you're gonna have to figure out why they have pain.
When you challenge them, you'll find when you're doing your assessment, and if it's an FRS lesion and they're coming into an extension, because now you're kind of localizing to the segment, you're typically going to have the response, oh, that's it. Oh, it's right there. It's right under your thumb. But in general, until you're starting to do your assessment, they're going to say that they have that achy feeling back there. It could be sharp as well. Same thing with the extension lesions. It's local to the joint. Joanne?
Do they usually accompany with like spasm of the muscles when it's like really acute?
If it's acute,
Or no?
you're going to see, you might have protective guarding if it's acute. If it's more prolonged or chronic, you're definitely going to see changes in the myofascial tissue, because what will probably happen over the course of time, if you have an untreated type 2, it will cause and facilitate a type 1. So that then you have that compensatory side bending depending on which way the segment is rotated. And I threw those up on the boards last class, showing you that if anything is rotated to the right, the curve above is going to bend to the left, and the curve below is going to bend to the right. Get underneath the dysfunction. It's like this. So if you have an FRS or an ERS to the left, the curve above it is going to go opposite. The curve below it is going to go to the same side. And if you had an FRS or an ERS to the right, the compensatory curve is going to go away from the side, while the compensatory curve is going to go under it. And that's all in an effort to make sure that we're going horizontal with the plane, or we have our body underneath the dysfunction to support it. If it went in the opposite directions, you'd be way off base. Especially, let's take the one on the left. If I was like this, if I go further this way, I have to run the risk of tipping to the side. And same thing above. If I'm here, I'm this way, I want to look this way to see where I'm going straight. That's the difference with the above and below. So you'll see that kind of presentation. Clear? Okay, good. So let's get back to treating the FRS on page 305. Yeah, sure. Yeah, thanks. Oh, you can sit right here. It's in a seated position. What's important to do for the patient with their feet? Have them supported. If I go too low, though, you guys won't be able to see, so I'm going to get a stool.
This is similar to the thoracic one.
Yes, it is. Sorry?
Raise her shirt says Dr. Williams.
Oh, there you go. That's the way to do it. That's it. As long as I can tuck one under something. So, what you want to do is you want to have contacts, obviously, at the spaces. And you can see it already talks you through it in step 1. At the interspinous space, you want to have the left index finger. And at the left transverse process, you want to have the left middle finger. So,
We're
on
on
3.
on the left again,
Yep.
but we're closing on the right.
We will be closing on the left. Yep. But right now, because of the position, which TP is prominent if it's an FRS to the left? The left is prominent. The left is prominent, so it gives
Only if it's
me...
a major.
True. Yeah, if it's a major and we're in neutral. Very good, thank you, Doctor. So when we get out of here at 5:30 today, I'm only kidding. Totally turns them around. Interspinous space because you want to be monitoring eventually for the big movement of extension, all right? And on the left side because you want to have some kind of landmark to follow, and that's going to be the transverse process at this point. Okay? So the first thing that we want to do is we want to create the situation for gapping. Eventually, what we're going to end up doing is coming here. But if we try to do that too quick, too fast, we can cause an impingement perhaps of the capsule or the meniscoid tissues in the right facet joint. So what we're going to do instead is we're going to translate the knee to the right, causing left side bend, okay, and keeping her neutral, and we're going to right rotate her. Okay. So I translate her right. I'm getting left side bend. And I want to now start to rotate her right to help bring the facet joint towards the right because it's not closing on the right. And what I can do now from this position, just apply maybe 2 cycles of muscle energy through the shoulder. Nick, what I'd like for you to do is I'd like for you to try to rotate towards the left, but I'm going to block your right shoulder from doing that. Hold, 2, 3, 4, 5, relax. 2, 3, further rotation, further translation. Keep the gap going. Okay. Now already I'm starting to feel the transverse process on the left move away from my finger, so I know we're being successful here. Again, rotation left. Hold, 2, 3, 4, 5, relax. And I continue to rotate, a little bit of translation. I'm pretty satisfied now with the position of the transverse process. So now what we're going to do is we're going to translate the opposite direction and promote side bending now to the right. And I'm also going to give a slight P to A with my fingers to facilitate extension at that level. It's going to look like this. Translate this way for the side bend and push your belly forward, helping with the extension. And there you go. All right? So right now, I have her in extension, side bending, and rotation to the right. I can now come here, my contact, and ask her for side bending left, and a little bit of flexion. Hold, 2, 3, 4, 5, relax, 2, 3, a little bit more extension, side bend rotation. And one more time. And relax, 2, 3, more extension, side bend rotation. Okay? And then very similar to the way that we finished the ERS correction with bilateral flexion, we're now going to finish with bilateral extension. So we're going to move L4 under the wave of L3. So I'm now going to support L4 segment with either my fist. It's easier to do that, and you don't have to string your fingers. And then bring her into bilateral extension. I can again impart a muscle energy contraction here. Try to bend forward, hold, relax, and then further extension. Okay? And you can repeat that cycle too. Go back and reassess. We should then see that if she comes into an extension bias position, then now we have symmetry, because we treated out the FRS that was getting asymmetric in extension, though if we checked it in flexion, it would be symmetric. Okay. A couple of you, before we go on to the technique for you to practice, a couple of you kept asking me, what's the difference between side bending and translation? Let me just demonstrate that quickly so you can see. I could, if I want to side bend Denise to the left, let's say, come to the side. This has nothing to do with the technique we just learned, or that I just demonstrated. It's just the translation. I can either, if I want to side bend here, and drop this arm down to the side. To get side bending all the way down here, I'm going to have to do that. How balanced over her base of support is she? If I took my hand away, you saw already she went to grab for the table, right? So I could certainly get side bending by side bending the person. If I translate away, however, there's the same side bending at my segment, but she's over her base of support, and she doesn't have to feel unbalanced. That's the whole reason why we implement, or you'll hear me say often translate, or you'll see it in the text as translate. It keeps the person more over their base of support. It helps you get to the feather edge barrier without having now to worry about holding your patient in place. Because they will feel like they're going to fall from time to time, depending on the positions you place them in. And you could reassure them on several different occasions that that won't be the case. But it's nice to really work with the translation. Just always remember, if you're translating in one direction, you're actually side bending opposite. So just think about the side bending that you want to occur and institute the appropriate translation. I just wanted to at least demonstrate it here, because with the lumbar spine, it's nice and easy to see.